Welcome to The Explainer. Today, we're diving into a really common but pretty complex medical question. You've got a surgery on the calendar, but you take a daily blood thinner. So, what happens now? Let's break down that crucial balancing act. Okay, so you've got the date circled, you're mentally prepping for the procedure, but then there's this one huge variable, that daily pill you take to prevent blood clots. And all of a sudden, what seemed like a routine surgery, it feels way more complicated, right? Do you stop taking it? When do you start again? And honestly, what are the risks if you get it wrong? The entire decision really boils down to this one big idea. It's a balancing act. On one side of the scale, you have the risk of thrombosis. That's a dangerous blood clot forming if you stop your medication. But on the other side, you've got the risk of hemorrhage. That's major bleeding during or after the surgery if that medicine is still in your system. The whole goal is to find that perfect sweet spot for a safe outcome.
All right, so let's actually put some weight on each side of that scale, shall we? Because understanding exactly what's at stake is really the first step in making a safe plan. First things first, let's remember why you're on a blood thinner. It's not for a trivial reason, that's for sure. It's usually to prevent something really serious, like stroke, a clot in your lungs, or a clot forming on a mechanical heart valve. So stopping that protection, even for just a few days, is a big deal.
So just how high are the stakes? Well, an analysis in The Lancet really puts it into perspective. An embolic stroke, the exact thing your medication might be preventing, could have a fatality rate as high as 37%. And that number, wow, it just shows you why pausing your medication isn't a decision you make lightly. And the specific risk really depends on your condition. For a clot on a mechanical heart valve, the fatality rate is over 17%. For a VTE, a clot in the leg or lungs, it's up to 10%. Every single one of these numbers is a powerful reason why your medical team is so incredibly careful about this.
Okay, so let's tip the scale the other way. Think about it from the surgeon's perspective. Trying to operate on a patient whose blood can't clot the way it's supposed to, that's a huge concern. A tiny bleed that would normally be no big deal can suddenly become a really significant, even life-threatening problem.
And yeah, just like with clotting, this isn't some tiny theoretical risk. It's very, very real. Research estimates that if a major bleeding event happens around the time of surgery, it carries a mortality rate of 6 to 10%. So the bottom line is, both sides of this balancing act are serious, and both have to be managed perfectly.
So how in the world do doctors make this call? Well, it's not a guess, and it's definitely not a coin flip. It's a very systematic, personalized assessment. Let's take a look at how they actually build a clear picture of your specific risk. Doctors use these validated tools, like something called the CH2DS2-VASC score. The easiest way to think about it is like a point system. They add up points for your specific risk factors for clotting, and that gives them a score. That score then tells them if your personal risk is low, moderate, or high. It turns a vague worry into a specific, quantifiable level of risk.
So what are they actually looking at? Well, they're looking at your specific medical history. Why are you on the anticoagulant in the first place? Have you ever had a stroke or a mini stroke? What type of heart valve do you have, if you have one? And this one's a big one. Have you had a clot within the last 3 months? That last one automatically puts you in a much higher risk category.
And then, of course, there's the other big piece of the puzzle, the surgery itself. Not all surgeries are created equal when it comes to bleeding risk. Something like cataract surgery or a simple endoscopy, that's pretty low risk. But a major surgery inside your chest or abdomen, or a big orthopedic or vascular procedure, oh yeah, that's high risk, and the plan for that is going to be way more cautious. Okay, so the risks are weighed, they're classified. Now what? Now it's time to create the game plan. This is where we get into the nitty-gritty, the actual strategies for getting you through surgery safely.
The game plan really depends on the exact drug you're taking. For a long, long time, the standard was Warfarin. It works great, but as you can see, it needs constant monitoring with blood tests and has to be stopped about 5 days before a big surgery. But these modern drugs, the DOACs, they're much more predictable. They clear out of your system faster, so they're often stopped just 48 hours beforehand.
And honestly, one of the huge advantages with these newer DOACs is just how clear the guidelines have become. For a low-risk procedure, you typically hold the medication for just 1 or 2 days. For a high-risk surgery, it's more like 2 to 3 days. This simple, time-based plan has made things so much more straightforward and safer for everyone. Now, I'm sure some of you have heard the term bridging therapy. For years, this was super common, especially for patients on warfarin. The whole idea was to bridge the gap when the long-acting drug was stopped by using a short-acting injectable one instead. And look at this process. It was a lot. You'd stop your main drug, start giving yourself shots of heparin, stop those shots a day before surgery, then restart everything afterwards. For a long time, we thought this was the safest way to do it. But it turns out the latest evidence shows that what we thought was safest often wasn't. And here it is. This is the big shift in thinking. The most recent guidelines from the American College of Cardiology and the American Heart Association are crystal clear. Routine bridging is not recommended. And why is that? Well, major studies found that for most people, it didn't actually prevent more clots, but it did significantly increase the risk of major bleeding. So, does this mean bridging is dead and gone? Well, not entirely, but it's now reserved for a tiny group of patients who are at the absolute highest risk of clotting. We're talking about someone with an older type of mechanical heart valve or someone who's had a huge clot in just the last few months. For almost everyone else, the simpler stop and restart plan is the new standard of care. All right, let's bring this all home. After all of that, what is the single most important thing you need to remember? It's this. There is no single universal rule. This is not a one-size-fits-all situation, not even close. The right plan for you is a personalized one, completely tailored to your specific clot risk, your specific bleeding risk, and the exact surgery that you're having. And creating that plan, it's a team sport. It absolutely requires clear communication between your surgeon, the doctor who prescribes your medication, and your anesthesiologist. But the most vital person on that team is you. Your job is to ask questions, make sure you understand the plan, and feel comfortable with it. You know, this whole move away from routine bridging towards these simpler, timed protocols for the newer drugs, it shows a really clear trend. And it leaves us with one final thought. As these medications keep getting better, safer, and more predictable, will we eventually reach a point where managing them around surgery becomes as simple as your doctor just saying, "Hey, just skip tomorrow's dose"? For now, it remains a very careful balancing act.